Okay, this session is going to be recorded, so I think we could start, and then people who is coming, they can review the recording. My name is Ismael Said Criado. I'm an internist in Spain, and as you may know, I'm the coordinator of the working group of telemedicine, new technologies, and e-health of the EFIM, the European Federation of Internal Medicine. And I'm glad to present three of my colleagues in this working group just to chat in this time, in this 90 minutes, about how it's going to be transformed, the clinical reasoning in internal medicine. I would like to introduce Professor Mahmood Adil first, who is going to talk about quality of clinical data to enhance decision making. He's right now the clinical data and digital health lead in the Royal College of Physicians of Edinburgh, and he was in the past advisor of the Ministry of Public Health of Qatar. He's an advisor and very expert in the digital medicine, and I think we are going to learn a lot with his point of view. I'm also presenting Dr. Filomena Pietrantonio, who is the director of the Department of Internal Medicine in Azienda Roma 6. And also she's the treasurer of EFIM, but the former coordinator of this working group. She's going to talk about the barriers in redefining clinical performance with new technologies in our clinical field. And after them, is going to talk Professor Henrique Martins, who is also an internist, PhD in management and master in public law. And it's also an associate professor in Instituto Universitario de Lisboa in Portugal and digital consultant. He was also former president of the Portugal's Digital Health Agency. He's going to talk about new skills for internists in the era of AI. So we will have these 90 minutes. We will let them 20 minutes to make their presentation first. And after all of them, we will give the opportunity to make any questions and have a discussion with them. So please, Professor Adil, your turn. Thank you.
Thank you, Dr. Ismail, and thank you for organizing this seminar or webinar, because always a good opportunity to exchange our views. But ultimately, the goal is that we should be able to help our patients with the knowledge we are going to create with such webinars. So I will run about 20 minutes presentation and then subsequently listen to my colleagues, Filomena and Henrique, and then we'll have some discussion on the points I raised or other colleague raised. So I'm trying to share and then see what happened. Can you see my screen?
Yes, we can.
Is my presentation is there?
Yes, it is.
Yes.
Excellent, excellent. Thank you. So, colleagues, I think a very good evening. And the topic given to me is the quality of clinical data to enhance the clinical decision-making or decision-making in our profession. And I think this is part of the webinar, which is the overarching theme is the transformation of clinical reasoning and internal medicine using all the digital tools. I think I'm very clear that the aim of our webinar is to understand how digital innovation is reshaping clinical decision-making process and supporting internal medicine professionals' daily practice. And my session, which you kindly given me 20 minutes, is to explore the role of healthcare data quality in improving the clinical decision-making. So it is the healthcare data quality I'm going to focus on. So before I jump on to the healthcare quality data, look at this graph. I mean, this is the way our profession has changed in the last 100 years. So if you go back to 19th century and you look at the most common causes of mortality is pneumonia, tuberculosis, gastrointestinal infection, heart diseases. Look at what's happening now. Heart diseases, cancer, diabetes, and these are the chronic diseases. So this is a very good article published by the New England Journal of Medicine. And the lesson to me is that when we are facing the new challenges, we need to use the new tools. And our profession needs to think that how best we can change our clinical decision making systems, how best we can use the data in digital health, and of course, how best we can use artificial intelligence, which is underpinned by data. So new challenges, new tools. So that is the theme. So let me start by saying that if the common thread among our talk is the clinical decision support, then it is actually the digital tools that are used in the healthcare to enhance the clinical decision making and deliver better patient care. So basically, it provides clinician with a virtual assistant to make the best decisions for patients. But we need to remember that if we are thinking about any such tools, they are ultimately underpinned by a large volume of health data. And that is where the quality of data comes into play. But what does these tools do? Very typical what we do in our day lives as a clinicians: improve diagnostic accuracy, optimize treatment plans, reduced healthcare costs, and ultimately enhance patient safety and outcomes. So that is the ultimate goal of using the high quality data to improve our clinical decision making, whether we are doing it ourselves or we are using any digital tools. So with that background in mind, let me say that data quantity and data quality go hand in hand. We cannot jump to data quality before we think about data quantity, because as we know that the more data we have, the better outcomes. And then we need to think about the data quality, that how much data we have, is it of a good quality? So the message from this slide to all of you is that data quantity and data quality goes hand in hand. And when I talk about data quantity, we are all the time use the word clinical data, and I am a big believer of health data, and this is what I have put over there. When we think about clinical data, we think about symptoms, investigations, treatment. And most of the hospitals in Europe, we have got EMRs, electronic medical record, and chances are they will be able to capture most of the clinical data. But the question is that if we want to improve the patient outcomes, then we need to think about the other sources of data. And that is where the quantity of data comes into play. So I put omics, mean genomics and proteomics, and these are very specialized tests we can do on patients, and that can give us more insight. Lifestyle data, which is very, very important. As I mentioned, that most of the challenges we are facing now are chronic diseases, and these are underpinned by smoking, alcohol, exercise, diet. And if we have the data on a patient or on a population, then it means that we would be able to make the right clinical decisions or better clinical decisions. And then the most important is the social determinants of health data. And there are very few health systems in the world, in particular, for example, Scandinavian countries, they collect that data very rigorously. And of course, in Scotland, we are doing it as well. So the message to all of us is that when we think about quantity of data, we need to go beyond the clinical data. And we need to start thinking, is in our systems or for my patient, do I have the data on the lifestyle and social determinants? And if possible, we can get some omics data. So this is the slide which shows that most of the health system, and I'm using Scotland here, that we collect data from pre-cradle to grave, that before the child is born, the maternity care, and then every interaction with the health system. In this slide, it is healthcare system. And there is a difference between health and healthcare system. And again, the health is physical, mental, and social well-being, and healthcare is mostly the physical health. And most of the data I have shown over here is based on the healthcare data, and it is being collected very rigorously. And there are almost 200 data sets, and they're almost 100% complete, 5.4 million population of the country, and all the data is being collected at one place. And it means that anyone who would like to do some further work, they have got one-stop shop to get the data, to understand the data. And if we need to improve the patient outcome for a particular disease, it means all the data at one place. In many countries, that is not the case, but this is the position in Scotland and many other countries. And I already mentioned about the social determinants of health data. And again, I'm trying to emphasize the point that we need to think about the quantity of data while we are thinking to improve the patient health outcome. And the social determinants are income, employment, education. For example, in Scotland, we divided the country into 6,976 data zones. And there are almost 760 people live in each data zone, and we collect data on all those things on those patients. And these are the social determinants of health data. And the SIM stand for that it is the multiple deprivation data. So now, once we have got the data in hand, how best we can improve the value of that data for our internal medicine practice. And this is where I start saying that you can start with descriptive analytic. Basically, it means it can tell you that how many patients have got a particular disease. I will use the example of diabetes, right? So it may say that in the country, we have got almost 350,000 people with diabetes, and what their age, what their ethnicity. So this is about the description or descriptive analytics. We want to move further to use that data effectively. Then we move into the predictive analytics. It means who is going to get the diabetes. So the data can help us to identify the people with help of all the data types I mentioned, that who is going to get the diabetes. So it means that we can work with those people, and then we can prevent the diabetes, or we can delay the onset of diabetes. And then the most valuable proposition would be prescriptive analytic. It means what can you do most effectively in order to improve the patient outcome, the data you have got in hand. So again, descriptive analytic, predictive analytic, and prescriptive analytic. So this is data value trajectory. So ultimately, what we are trying to achieve is that enhancing the patient outcomes. In the UK, and I think most of the European countries, we use the definition of quality based on 3 pillars. That we provide safe care, that the patient shouldn't suffer no harm. We should provide effective care, it means receiving evidence-based treatment, and we should improve the patient experience through the health system. So if you have got high volume, high quality data, then we can use the data to achieve those 3 goals and basically enhancing patients' outcome. So I like to use diabetes because first it is internal medicine. Most of the internal medicine physicians are very good in dealing with diabetes. 1 in 11 adults in Europe has got diabetes, 67 million by 2023, and 1.1 million deaths every year because of the diabetes. So it means 1 in 3 adults in Europe are undiagnosed with diabetes as well. So if this is a challenging position, then here are some of the examples where high quality data and high quantity data has been used through the digital means to improve the patient outcomes. First of all, the clinical decision supports, because a lot of algorithms have been developed by utilizing all the health data. And those algorithms are helping us to do the right prescription. I mentioned the word prescriptive medicine, or sorry, the prescriptive analytic. And it means that we can improve the patient outcome by prescribing the right treatment for the right patients at the right time. Self-management tools being developed. There are a lot of very valuable apps which are available, and some are being linked with the insulin pumps, but others are available to the patients so that they can change their diet, and so the patient outcome will improve. I already mentioned the predictive analytic. That is again based on data, diabetes prediction, risk stratification. And there are wonderful, validated tools which can help you to predict the patient who is going to get the diabetes. In the UK, we have got the GP practices. Everyone is registered with a GP practice, and these predictive tools are being used in the GP practice to predict your scores, that what are your chances to get diabetes in the coming years. Diabetes retinopathy screening, which is again underpinned by AI algorithms, and of course the diabetes education. So this is again using one example which shows that how data can help you to improve patient outcomes. Now I will come to the crux or the focus of this session, which is the data quality metrics. So when we use the word data quality, it is not a buzzword. It is underpinned by 6 themes, right? First of all is the accuracy. Accuracy means that whatever data you collect, you need to be very clear from the outset what is the purpose of collecting that data. So if I keep using the example of diabetes, then it means that you will be able to understand or make it more tangible. So when we say that we have got a good, accurate diabetes data in Scotland or in any other country, then it means that the data is being collected with the purpose of improving patient outcome with diabetes. And that means the accuracy of that data. The validity of the data is for example, validity means that if there are certain parameters which are pertinent, then the data won't be validated without those. I can give you 1 or 2 examples. For example, that if the gender is going to affect the treatment or the patient outcomes or the chances of predicting their score, then if you don't have the data on the gender of the patient in your record, then the data is not validated. Then third is reliability. And the reliability, you need to remember that there is not one source of data. Patient is being seen in different hospitals. Those hospitals EMR are going to get linked. When we use the word reliability, it means repeatability. So if I ask the system to give me the data on all the patients with diabetes in Scotland, it should give me the same data every time I'm going to ask it. So it should say there are 350,000 patients with diabetes, their HbA1c is this, and then 60% of them are male or 40% of them are female. So this means the reliability. And cohesiveness means that the incomplete and incorrect data. So if you want to make sure that the data is not complete, whatever data we collect, and then it is not incorrect. For example, the birthday is being used as a unique identifier in many countries to link the data. But if your date of birth is not being logged correctly in different places, it means we won't be able, or system won't be able to link that data. So that is cohesiveness. And then the uniqueness, again, there are many good examples that the high uniqueness score means that there is less duplication. So the data is not duplicated. Yes, we do have tools to clean the data and we can do that, but high uniqueness means the data is not duplicated, and timeliness means that it should be available at the right time, at the right place, so that the data shouldn't be lagged 1 year. It is too late. So all the health systems nowadays are trying to make sure that we have a timeliness data. Then if I give you an example to put some more, shed more light, what is meant by poor quality data? The first one I put is inaccurate or incomplete patient information. Date of birth is not there, gender is not there, or the last name is not there, or it is incorrect. So this is one example. Inconsistency in terminology and coding. So most of the health systems using ICD-10 or ICD-11. And if there are inconsistency in terminology and coding, then it means that we would be getting a wrong diagnosis. Duplicate records does cause a lot of challenges. and data integration challenge. As I said, there are different health systems, there are different systems in one country, in one hospital, lab system, clinical systems, and if there's not good integration, it means we will get poor quality data. So just remember them as an example of poor quality data. And again, how we can deal with the poor quality data, it means we need to standardize it. And there are almost 40 organizations across the globe. They are trying to standardize the data. I don't want to go into details, but in simple, there are 4 areas where they're trying to standardize it. The first one is the most important one. For example, healthcare data exchange standards. So when the data get exchanged between the 2 systems, then there need to be certain standard. We call one of the good standard being used in most of the world is the FHIR. Then data privacy and security standards, terminology standards, as I said, SNOMED is there, ICD 10 and 11 is there, and then the content standard, that how the contents are going to be collected and they are going to be standardized. We are getting the ambient speech, and it means that content gets standardized and then they can get integrated into the health systems. So last 2 slides just to say that if you want to have a prerequisite for a successful clinical decisions, first of all, we need to have a stakeholder buying. And who are the biggest stakeholder? The physicians are the biggest stakeholders, not the IT departments. So this is where I say that we need to be developing the data literacy, digital literacy among the physicians. Second is the clinical governance structures. So it means that we need to have evidence-based guidance. We need to be very clear that when things goes wrong, who's responsible and how we are going to correct it. Because the people biggest hesitation to use the modern tools are, if thing goes wrong, who is going to be responsible? So that means you need to have a good clinical governance structure in place. Then appropriate interoperability standard, I already mentioned, and the human aspect change management. You as a leader, because you joined this webinar, itself says that you are interested, you are keen, and you are going to be a very good change agent and catalyst in your organization. And these are the prerequisites for the successful clinical decision making. Let me say that my goal within the Royal College, and I think we collectively say that we need to have we need to improve the data and digital health literacy for clinicians. What is that? Ability to access, understand, use, and share data and digital tools to improve health outcomes. I use the example of diabetes. And I always challenge my colleagues in the past, asking them, can you tell me that are you able to get the data of your patient with diabetes? Can you access it? Can you understand it? And can you use the tools? And if they are not, then it means that they don't have the basic literacy. And we are not talking about the postgraduate qualifications. And I'm sure my colleagues are going to talk further about this. So in summary, I would say it's a changing time and changing practice. We have done the wonders in the past as physicians, and we use stethoscope as the main tool. But now the time has come, we need to think about the data scope, and this journey is underpinned by better quality data. It will lead to better practice, and it will lead to better outcomes. Thank you.
Thank you very much, Mahmood. Really, really interesting. So now, Filomena, it's your turn.
Yeah. Okay. Okay. So I don't know. I will start to share my. Did you see my screen?
Yes, thank you. Now we see it.
Okay. I don't know if I wanted to start with a surprise, but probably I don't know if my surprise is online. I don't know, because in this moment probably is not online, but if he will...
I am. Is there.
Ah, you are. Okay, okay, very good. So because I am Italian, I like very much surprises. And I want to present to you my surprise this afternoon. My surprise is, the name is Oleg Missiko, He's a professor of humanity and social science at University of Rome, Sapienza University, and is also an expert of artificial intelligence. He will give us some introduction to my presentation with a new insight about the relationship between human and artificial intelligence. So please, Oleg, thank you to be here with us, and it's your turn. Hello, Oleg.
You hear me?
Yes, yes.
Good, good. Okay, good evening, everybody. Actually, it's a surprise for me too, because Filomena told me about this very, very, very recently. So, and I'm sorry for the line if it's bad, because I'm in actually currently in Malawi in Africa, and so the line is not so good. Anyway, I'll be very, very quick because I know that the time is tight. And what I want to tell you this evening is that I just discovered, is a very recent thing that I discovered in the last week or 2 weeks. While I was creating a crash course for the government of Guinea in Africa on how to adopt, integrate AI in parliamentary works and in writing their new constitution, which is a very, very interesting work. So what is basically the problem in this moment is of the relationships between humans and artificial intelligence, because as we see everywhere, the positions span from thinking that AI will destroy the world to thinking that AI will solve all our problems in a matter of months. Obviously, none of those is true. But what is a really amazing discovery I did so recently is that we can actually influence the behavior of artificial intelligence, and especially generative artificial intelligence. We know that often there is a sort of mistrust, and then there is the tendency to treat AI and AI tools as cold machines to extract, to make sense of big data, or to extract information, or to help in writing, and this kind of activities. However, what I just discovered, and then I made a little bit of research, and I found out that it is an emerging approach towards artificial intelligence, which is called vibe prompting. Everybody that works with artificial intelligence knows what is prompt engineering, which is the capacity to actually interact in natural language with AI tools, generative AI tools. What I discovered as I was preparing a course for non-technicians, because this is directed to basically policymakers, politicians, and the government in general. So I started to introduce elements of local culture, of even religion, of anthropology, local languages. And when I was starting to do, let's say, strange things, I noticed that the behavior of AI changed radically. I mean, we tend to be very professional, very, very precise in the way we interact with artificial intelligence. So we would never think of telling AI how we feel, for example. It would sound strange. However, and especially, I mean, if we talk about technologists like doctors, because doctors they studied medicine, they didn't study computer science or electronic engineering. I mean, they are doctors. Even more with patients. I mean, if we talk about creating assistants that could help elderly people or children, I mean, in that case, to have an AI which is more humanized, let's say, it would be a great advantage. So I'm just here very quickly to tell you, from now on, when you interact with, I don't know, Gemini or ChatGPT or Perplexity, no matter what tool you decide to use, try to introduce elements that you would never introduce, like your feelings or your fears that the use that will be done will not be appropriate. I mean, all these kind of internal thoughts that we as humans have. But when we interact with technology, we tend to exclude them and be very precise and specific on the goal and the task we have to fulfill. So I close here. I hope I didn't get too much of your time. What I'm asking, I mean, I'm suggesting you to try. First of all, look for vibe prompting, and then when you interact with AI, just try. There's nothing to lose. Just try to change your attitude and think that you're interacting with an entity that is able to mirror your feelings and help you in finding the best way. This is a bridge, would be a bridge to fill the gap between humans and artificial intelligence. Thank you very much. That's it.
Thank you very much, Oleg, and thank you for this surprise. I hope you appreciate it. It was very interesting for me, and I think that it could be very interesting also for people that is participating to our seminar. So now we start with my presentation, and this is the agenda. This is we start with something that is linked to what Professor Mahmood Adil said. It was very interesting presentation, and it's a link to what I will say in this presentation very quickly because we lose some time. So I will be in time. So digital competency for doctors and the WHO views on artificial intelligence, because I don't know, as you know, I'm working in developing countries, that for me, the WHO point is very important. Decision-making in internal medicine, so the potential role of artificial intelligence, key challenges for delivering clinical impact with artificial intelligence, the barriers, that is the title of my presentation, and also is another surprise. We were working about our position paper on EFIM about artificial intelligence. So I will give to you some insights of this position paper that currently is, it was sent by to Lancet Digital. So we put very high. So digital competencies, already Professor told about the digital competencies. I just want to say that there are a lot of tools, there are a lot of domain and topics that we can discuss. So we will have only a few times. So I will try to, as I was saying to Ismail, I will tell to you only the things that frightened me, that the things that were for me the most interesting about a very huge mass of data about the barriers on the application use of artificial intelligence. In particular, I want to tell you that for me, it's very important, the literacy. That was also the point that was underlined by the professor, and I think it's a point, a very important point. And we are very convinced that the role of a society like EFIM is to improve the literacy about all these arguments. So it's the way, the reason that we organize this kind of happenings. And So also another point that I think is very important is that the digital transformation is very, very quick, and the COVID-19 was a most important point in developing very quickly all the tools that we are talking about. And this is the point. I was very interested by this, because there are a lot of tools that were developed by WHO about how to use artificial intelligence to improve the outcome, as said Professor Mahmood. So enable, facilitate, and implement sustainable model of AI at country level, because it can be one of the tools that we can use to improve and to reach the development goals. And I think it's very important because it's a global approach in the use of artificial intelligence. And WHO strives robust governance structures, so enable, so improve policies and normative and guidance and standard for the adoption of this practice. Collaborative efforts and investment, it was another point that also Professor Mahmood was discussing, and develop, and also another important point I think is the sustainable models, because is another important point, because we want to use it, and that this model could be sustainable all over the world. These are all what is published by WHO, and is the priority areas of work, and also the WHO approach. And these are all the QR of the document that were produced by WHO. So this is really a global problem, and I think it's very important to have a global approach in the use of artificial intelligence. So we can use it to improve so this is the other point, is the potential role of artificial intelligence in clinical decision making. So what I did is to read, to find some literature about that. Is full of meta-analysis, review, discussion. It's really easily, there are a lot of things, and I tried to choose what could be interesting for us. And in general, the first clinical question was if artificial intelligence can be used as an alternative to physician assessment. Because this was one of the point, you know, one of the fear of the doctors, that can be used instead of me, so I'm not useful. And luckily, I think that is not really like that, because also what said Oleg was very interesting. I think that is that the artificial intelligence needs the human, so it's not something that is standalone, and needs also the human to develop in a way that is useful for our job. And there are a lot of studies about image interpretation, and this is really very useful, and is standardized, I will say. But and also there are a lot of evidence that the robot doctors, so artificial intelligence, could be better than is outperforming doctors. But really, if we look at other papers and other studies, we can see that sometimes there are some studies highlights that there are no significant differences between the use of GPT-4 and the clinical reasoning. So something is not really, so we need more studies to see really in which way I could really assist our process of decision process, and also improve our outcomes. And there are randomized studies to evaluate, for example, whether implementing these tools can be better than the conventional clinical decision using, for example, resources like UpToDate. And this study didn't find the statistical differences between diagnosis performance between AI assisted and AI assisted and conventional groups. And so there is a strong evidence that we can improve our performance, but really doctors' needs are needed anyway. And really what AI lacks is the ability to recreate human-human relationship. So it's for that I asked colleagues to tell us these new studies, because probably if we improve the relationship with the AI, we can improve also this problem, this topic about the lack of ability to recreate human-human relationship. And so what are the key challenges for delivering clinical impact with artificial intelligence? So there is a clear evidence that artificial intelligence research is accelerating, and there are many examples that it can use it in a very good way in a clinical practice. And but there are also potential dangers like dataset shift, accidental fitting of confounders, unintended discriminatory bias. It was very interesting, again, the presentation of professor that explained very well that the data, they could be mistaken taking data and interpreting data according to where, in which way you collect data and you choose data. So these are really important points that has to be taken in account when we use artificial intelligence, and also when we use it to improve the clinical impact of our job. And which are the key characteristics of medical innovation? The relationship, the complex relationship medical innovation has with demand and need, the critical importance of various forms of scientific knowledge and collaboration, and also the centrality of governments and regulation that are also very important points. And as were presented by Professor, there are these computerized diagnostic decision support that are very, very important to improve, to enhance clinical decision making. And with the artificial intelligence and the approach of AI approach, we can really improve our diagnosis, shortening the time of disease detection and diagnostic accuracy, and reducing medical errors. And also we can improve also the feeling of the doctors, so reduce the cognitive burden, mitigate burnout, and enhance care quality. So really we can reduce what can be done by the machine, and reduce the workload of the doctors to improve the quality of diagnosis. And these are, I found that I like very much figures, so I present to you this just to see that there are this article is very interesting because it presents the levels of the different tools of AI diagnostic decision support, and and also the relationship between the tool and the role of clinician. As you can see in event monitoring, only AI is involved, but response execution, we have at different level, we have clinician and AI. So the message is that a clinician is always present in using AI. And this is very, very, very important for us. And which are the core support in the use of AI? In this paper, also this paper was very interesting, a discussion paper there is a model for understanding the key drivers of clinical adoption of these tools by health system. So there are different domains, reason to use. So, for example, the market forces, the reimbursement for policies that drive the healthcare investment of AI tools, the means to use, to human infrastructure components, the technical resources for deploying and maintaining these tools, the method use, so the workflow consideration, the training recruitment. So we were talking about literature, and desire to use. So this is also what Oleg was saying. If I feel that AI is a danger, it could be a danger for me, I will be less interested in using that. So really is a very complex interaction between human and AI and the use of AI tools. This is also very interesting. This is the same reason to use, means to use, so infrastructure and resources, the methods to use, efficiency and the workflow, and desire to use. That I think is really one of the core business in this in the use of these tools, and this is one of the things that we think really that is very important, that we know these new tools to trust them and to increase the desire to use it. So this is also our idea as a working group. Now, we want to know better, to help you to know better these tools and to increase your desire to use them. And also I was reading the systematic review of the barriers to implementation of artificial intelligence in healthcare. And we can see that the barriers are ethical, are technological, liability and regulatory. So also this is a very, very important. The workforce, social, and patient safety barriers. So there are a lot of potential barriers that can reduce the use of AI tools. And so it's very important for us to know better these tools, how to use them, and to trust them, to increase to use them and to increase the quality of healthcare that we can deliver. And we were talking about big data analytics, and it was we were not discussed before our presentation, but it's very, very I'm very happy that we were talking about the same things, I mean the same concept, the same topics, because qualitative and quantitative data and frameworks of analysis merge for outcomes in precision medical and population health. So it's very important the use of that data, both qualitative and quantitative, and that can help us to deliver a precision medicine and to target our treatment on the single patient, and primary care provider and social media bridge the gap between qualitative and quantitative data, as professors say, and elements of precision medicine and population health are connected between them. And this is another nice picture because I like them. I like it because it's the typical workflow from a patient encounter with a specialist provider. And this is mentioned the electronic health records. That is very important, but it's something that is in one sense, you know, it's very vertical and horizontal, but it's really the patient is in the center, but it's really in the hands of the doctor to merge, to use all the data that are inside the electronic health records and are collected by different actors, stakeholders. And in this way, if we use a healthcare data fusion and the management framework, so is a regulated framework for healthcare data management to accelerate the patient-centered care and improve the interoperability within a healthcare system. As you can see, if we have this kind of system, there is a cloud in which there are all the information cloud-based of the patient. And in this way is much more circular, the information. It's not vertical and horizontal. So it's something that really you can understand that is improving. It's really improving. And you understand much better what is the best pathway for the patient. This is what suggests is this article. So this the benefit and deliverable of a fused healthcare system. So it's response open, bridging, interoperable, and network based. And the characteristics are, the benefits are functionality of workflow of the information, accuracy of diagnosis, transfer between providers. This is very important. Efficiency of visits, management of data, and accessibility of medication. On the other side, you can see health monitoring, deliverables, accurate diagnosis, reimbursement by insurance, and precision prescriptions. So it's really to go towards 6P medicine. So very, very personalized and centered on the patient. And in this way, AI can really help us to accelerate, to improve this process. So barriers to the application of artificial intelligence in medicine. This is another important article, a systematic review in which were identified 19 teams organized in 3 levels: technical, algorithm, stakeholders, and society. So really, we are really connected to what said Professor in the first presentation. So technical is the first level. It's clear that it's very easy to understand. No, the validation protocols, standards, reporting guidelines, standardization of performances. Stakeholder level is another important point. So the provider, the patient-related concern, including literacy, and the loss of patient autonomy, the disturbing the patient clinical relationship, or I would say not disturbing, but changing. So the relationship has to be changed. And lack of trust in AI, that is our topic in the beginning, what said Oleg. Also organizational related changes, concern, logistical challenges, lack of strategic plan, lack of cost-effective analysis, and proof of efficacy. And a society level, so privacy, there is an important point. We will not discuss about that, but it's an important point. Liability, bias, and social justice and education. So this is just the same information, only in a figure. And so the major terms is the major terms is like no, aspetta, sbagliato, vabbè. So we pass to the hot points of our position paper, and I thank really Ismail, because after this the study that I did for this presentation, I understood better that we really did a good job with our position paper, because we centered this position paper on the 6P medicine, so personalized medicine. And I think that this is the point. This is the point. So this is one of the most important things that we can achieve using artificial intelligence. And so I'm really very happy that I did this job, because really we did a good job for this position paper. And I want just to give to you some insights, because it's something that we are trying to publish. We are waiting for Lancet Digital, that is a very important article, but we are normally, if we did a good job, we will try to present it to one of the best, all the best journal in this topic. So the European Federation of Internal Medicine recognized the transformative impact of AI in leveraging clinical data and advancing the field of internal medicine. So it's a very, very important point. So we strongly wanted to have a position paper on artificial intelligence in internal medicine, and explores this position paper explores how AI can be applied to achieve the goals of 6P medicine. And as we say in my presentation and also in the presentation of the professor, we are on the right way, I think. And an additional concept is that digital therapies that are software applications designed to prevent and manage disease are very important, and we have to consider them in the big platform that we have for the treatment of our patients. And what we did was we started with the review of the literature, and after we to be much more stronger in the preparation of our position paper, we did a Delphi panel constituted by 30 international AI internal medicine experts, and we realized, summarized in a SWOT analysis what came up from the panel. And the results was that the panel considered that AI in internal medicine is an opportunity, and AI-driven solutions, including the generative AI and digital therapeutics, all potential to change internal medicine, enhancing patient care and generating valuable data. And these technologies offer a path towards more efficient, personalized, and human-centered healthcare. And anyway, we thought that we saw that the few opportunities for expansion or improvement were seen, and this is a pattern typical of a disruptive technologies that organically change their field of application. So what we say as EFIM is that AI application in internal medicine offer significant opportunities to improve efficiency and quality of care and reduce, this is another important point, administrative burdens, so reduce also burnout and improve the quality of doctors doctors and nurses working on the patient, so increase the time that we can give to the patient instead of give to the administrative work. And so we recommend that specialists, the physician in internal medicine, take a leading role, and societies, scientific society, take a leading role in education. And this is one example, this seminar, designing and implementation and evaluation and regulation of AI in clinical settings. So I close, so quite in time, I hope. So take-home messages. Take-home messages, I was thinking about what we can say in these take-home messages. So I choose to say what we decided all together to put as the conclusion of the position paper, that the AI-driven solutions are, they have the potential to change strongly in a very important way the internal medicine workflow. It can enhance the patient care and generating valuable data. They are very important in offering personalized and human-centered healthcare. That is one of the most important things that is in the center of our activity as internal medicine specialists. The integration of such technologies in healthcare domains needs interdisciplinary collaboration. This is another important point. Care teams so involve new professional roles like clinical data scientists and bioengineers. And another important point is to adhere to EU regulation about ethical consideration and transparency. And patients and caregivers must remain at the center of our healthcare delivery. And so I say you hello. I thank you for the patience for this presentation, and I want to close with this. This is a very I think it's a very interesting phrase. Let the machine do the machine work, so the humans can do the human work. There is a little bit really related to the presentation of my slides, and so thank you very much.
Thank you, Filomena. It was very interesting. So now it's the turn of Professor Martins, maybe? Yes.
Hi.
Hello.
Thank you very much for
Filomena,
the invitation.
Excuse me,
So-
Filomena, can you stop your
Sí.
presentation? And so Professor can
Okay.
use it? Okay,
That's nice.
thank you.
Thank you very much for the invitation to participate on this discussion. I took, I think, a broader perspective, which I think complements well the previous speakers. My understanding of the new skills for the internist in the context of AI, and in order to cover that topic, I want to go back. Well, not back in time, but back in the scope. Because unfortunately, the preparation, the degree of skills that internists have in Europe and even outside Europe on digital and health is still very, very poor. So yes, we need to prepare to use AI, but in order to understand the topics that Filomena just eloquently presented and Mahmood, we need to know the basics. And so my first message is to understand the context and understand the basis of all of these technologies. And what is the context and what are the bases? So one thing that I think Filomena just finished, and it's always nice to link with the previous speaker, as they say, what is the purposes of all this? What is the purpose of digital health? And it is one of the 6 things that are written there for more than 20 years. Equitable, safe, efficient, patient-centered, timely, or efficiently in care. So if we are using AI or any other digital health solution and we are not aiming for any of these 6 things, we are not using it for the right purpose. We might be using it to have less work. Well, okay, then we're lazy. But okay, if we have less work and we have more time, then we're being more efficient. The question is, do we use that time for patient care, or do we use that time for just going out and have some drinks, which is not necessarily a bad thing for many internists that are clearly burned out, and they often exit their clinical path many years before they should because there's no enough life balance. So even if AI was there just to alleviate and make us more efficient, that would already be justified. But then let's measure that, because when emails showed up, people believed they would have less work and more free time, and didn't really happen. When WhatsApp and all the social media came up, everyone thought it would be wonderful, and then they are fighting with their daughters and their sons in the bathroom and in the dinner place. So let's make sure that this time with AI, we do it right. So when not to use AI could be the topic for the next panel, and when not to use it. And not to use it because it is bad or because it is harmful, but because we might not want to use it. And this is particularly a discussion when, for example, we're training clinical reasoning, when we're doing training to medical students or training to young internists or residents. This is important. So I will finish with that perspective. This is just the beginning. So I'll finish with that when not to. And there are good ethical reasons for doing things and for not doing things, as long as we have the conscience. Now, another thing that most internists should be made aware is the context. And one of the important things about the context is that data, information, and knowledge, and what we can call also meta-knowledge, are not the same thing. And people often talk about these as an interchangeable reality. They're not. So Mahmood presented, for example, 2 topics on interoperability, which lays at the level of data. But without good interoperability, we don't have meaningful information. So that the information the context with which we are going to understand the patient is not going to be there. And knowledge is rare. This is the first statement about knowledge. Knowledge and wisdom even more. And I'll go into that in a second. And then finally, and some of these, this slide is old, it's maybe 3 years old or 4, I don't mind saying it, but I want to highlight to you how, for example, the last challenge has become so real. In less than a few months, with changes in policy in the US, everyone's nervous about digital sovereignty. Many systems depend on one country only. And this is a big issue, especially in the AI. Most AI models, most AI clouding services, most of the large computing power lies on the hands on only one country. And I have no problems with the US, except when the US seems to have a problem with everyone. That becomes a problem for everyone if we're not careful. So there's never been such an urgency in the European Union and the European region, even broader than the European Union, to look at the topic of digital sovereignty. And we cannot, because we were enthusiastic about AI, move all our energy and depend on only one provider. As we say in Portugal, from where I'm from, you shouldn't put all your eggs in one basket. So hospitals, for example, should have redundant email systems of more than one provider. They don't. Today, if Microsoft decides to raise the tariffs 400%, you either pay it or you have to disconnect your emails and things like that. So this is an important topic. And why is this important? Because many internists are called to make decisions as chief medical information officers, as members of boards of hospitals, you know, and sometimes they're not aware of these contexts. This is a real important matter. One of the sovereignty that, you know, a few years ago, people didn't know, wow, what is that thing, digital sovereignty? But now people really understand. Anyway, let's move ahead. Now, sometimes people ask me, well, what about the systems of the future? So we're preparing internists, right? The question was skills for internists. Well, skills, I always like to remind people that, for example, when we're preparing a doctor that will graduate on the year 2030, he studies a curricula that starts in the year of 2024, and that medical curricula has been designed, best case scenario, in 2020. And he's going to work with this package of undergraduate education for at least 40 years, until 2070. So I tell you, we design in 20 what people are going to have to know until 50 years from now. Now imagine 50 years ago. No one could ever imagine that we would need to be prepared for using Zoom and things like that. I mean, we barely had the internet 15 years ago. So, and the speed is accelerating. So from 15 years from now, my best advice, read a paper that I published about the plugs of computers to brains and about brain-computer interface. That's the furthest I could imagine of what we are going to do for education, is to plug people and decide what type of software packages we run, and can people pay for that, and what happens if people don't have the money to connect to computers. Well, all sorts of crazy things, right? That people would say, oh, this is really crazy. But anyway, not so crazy, but I think still quite far away from in some countries, is the idea, two simple ideas in this slide. Self-care based on AI tools. This is not science fiction. Raymond Kurzweil, a very famous futurologist, wrote in a book, The Age of Intelligent Machines, more than 40 years ago, that computers would be analyzing ECGs, computers would be analyzing lab results, and doctors and nurses would have a little bit more time to do what they should do, to care, to be care professionals. This was almost 50 years ago, so he wasn't right, but you know what? AI software that analyzes ECG is still not there. Not good enough. Can you believe it? More than 1,000 PhDs after, we still don't have a super reliable as a good, well-trained internist or a cardiologist. So let's get enthusiastic, but let's also be realistic. What we do know, and this has already been discussed, is data needs to be of good quality. This is a major responsibility for doctors, especially internists. Internists, I'm an internist, I worked in a hospital, I've put an electronic health record in a hospital, and I know the wars I had with orthopedic surgeons and with internists. Orthopedic surgeons wanted to write less than 5 words to discharge a patient, and preferably, if the system was automated, they would be even happier. Internists wanted to access all the information. They were complaining that there were some missing records from 7 years ago. So this spirit of integration, of joining pieces together and on refining the quality of the care is really important. Because I would say today, maybe I've never said this, but I would clearly say hospitals need to start creating what I would call, now I'm just going to invent the word, data clinics. What is a data clinic? Is 20 minutes for a doctor to sit alone in front of a computer and clean up the mess, the data mess about a patient. Clean up the redundancies, 2 diagnoses that seem the same, but they're not. And 1 diagnosis that is repeated, and 2 medications that are slightly different, but 1 should not be there. Now, can you automate these? Can you use AI to do this? Yes, you can, but you need to first do it with humans so that an AI system can be designed, trained, and evaluated to correct the amount, the gigantic pile of useless data. Sometimes it's, oh, there's hundreds of terabytes of health data. Yes, there is hundreds of terabytes of data. That doesn't mean there's hundreds of terabytes of usable health data. And the solution lies on the simple activity that many internists do when they see the patient for the first time. Tell me everything about you. Bring all the medicines that you're taking in a bag. And if you have some exams at home, bring them as well. I'm sure many people recognize this conversation. We used to do it this way many years ago. Now we look at the computer and we believe it's all there and it's organized and it is well synthesized and that there's no mistakes. Well, that is completely not the case. Just go to your department and ask for a simple query. Diagnosis against gender, and you're going to find the most incredible diagnosis on women and men that shouldn't be there. So even at the level of just gender and diagnose, there are problems with quality of data. Without good quality of data, there is no good AI. There's no good AI. It's just now another thing internists need to know. They need to know who are the new digital patients. They need to know that patients are carrying AI with them, in them, and around them. Patients are the first users of AI. If you now go to a hospital in an emergency room, maybe the patients are using more AI than the nurses. They're using it on their phone. Some people have AI in their insulin pump, measurements to inject whatever dosage they need. And they're coming in all sorts of shapes and forms. So patients are becoming digital and they bring their own AIs. Some are good, some are bad, some are certified, some are just pirate material they downloaded from the internet or bought somewhere in a strange country somewhere. So this is a real complex world, but at least you need to know these exist, right? And you need to promote. This is an old slide that I got from N1 from the University of Oslo. She worked many years, and I've learned a lot with her on capacity of patients. And many years ago, you can see that this framework is from 2000. This idea of smart patients, self-assured, motivated, aware, resourceful, talented. So AI can help us on this because AI is the tool we know they have used. Right now, people do not go, well, they used to use Dr. Google, then they started using Dr. ChatGPT, and now they're going back to Dr. Google because Google went fast, and put an AI tool in Google because they were running out of market. So now they go back to Dr. AI Google, and they come up with all sorts of good ideas, and we shouldn't scare them away and should hear them. Oh, what did you do? Oh, I've used this thing. Oh, but you know that this is, AI, and there's mistakes, sometimes there's even hallucination, sometimes the AI. As I said, AI and technology in general is coming into the people. So we used to have portals and apps. Now we have devices and things that are plugged into our bodies. We will become bionic over time. Actually, I was just noticing here in the metro in Korea, there's no one walking in the metro without grabbing his phone on his hand. Now, this is not a true bionic because the phone is not connected to the bone yet, but I wouldn't be surprised that some teenagers wouldn't mind to actually connect their phone to their hand, if that would ensure that battery would never die. So the first startup that comes up with some energy out of ATPs from glucose and produces energy for the phone, I bet you some people will plug their cable from their phone to their artery, and they will charge their phone on their own blood sugar levels. And guess what? Burn some calories out of that. This is a good model. This is for Ismail when he opens his first startup based on digital things. But anyway, another skill, using digital to treat. I would say that in 5 years, there's no digital therapeutics that does not have elements of AI inside. Is that relevant? No. It's like thinking of a smartphone without a screen. All smartphones have a screen, touch screen. It's part of a smartphone. You don't think about it. Now, of course, there's touch screens that are better, touch screens that are worse, and the technology of touch screens improved tremendously in 20 years. But the point of digital therapeutics is, what do you use it for? Do you use it to substitute a drug, as you could do, for example, to substitute melatonin, for sleep disorders with digital interventions for sleep re-education? So randomized clinical control trials. This is an old slide. The many randomized trials have been published meanwhile. This was a small summary we did a few years ago. And digital therapeutics is there. Some countries are already reimbursing digital therapeutics. Germany, Belgium is deciding, Luxembourg, and so on. Another paradigm is care is going to be hybrid, like this session. Some people are in real time. Most people will listen to us later on. Maybe Ismail will create a podcast, take out our ugly faces from the screen and just get the voice. There's one thing we know: people do not consume care the same way anymore. They go face-to-face, then they call, then they do a Zoom, then they send their results via email, then tomorrow they use a platform. So this is hybrid. This hybrid healthcare system is the solution for the biggest problem we have: lack of access. And lack of access is not a problem just for poor people, like there is the case in some countries. It's also for quite rich people that are so busy, they cannot go to the primary care doctor or the internist because they're busy working. And for example, another lesson from Asia, they have 3 slots of consultations: morning, afternoon, and evening. So at 10 p.m., all hospitals are busy with people coming to outpatient appointments with their doctor. And you would think, oh, doctors are upset working at evening. No, they take a full day off, and at 7 p.m. they work until 11. No traffic, or much less traffic. Their patients are happy because they leave their work and they can go to see their doctor. Everyone's happy. And guess what? Hospital managers are happy because you don't have these stupid empty rooms, which completely unproductive. But guess what? Metaverse, telehealth, for another session. We don't have time. What I want to convey in this session is that all doctors need to understand these tools all have AI inside them. I'm not saying today, but in the next 5 to 5 years, for sure. There's not going to be one teleconsultation platform that doesn't do a summary of the teleconsultation with an AI algorithm, like we now have to summarize a meeting in Teams or in Zoom or any other teleconference platform. This is AI in telehealth. To learn to live with robots and computers in the same room. Surgeons have learned with Da Vinci. Internists have to learn. They haven't really got you the idea of this thing helping them make decisions and sitting together with them in the room, but we will get there. And then rights of patients. So this is for the European crowd from the European Health Data Space. This is the new regulation, January. Citizens gain tremendous rights. Right of access to data, right of downloading data, a lot of access rights and usability rights, which means that patients can ask for the data of the hospital, load it into an AI algorithm, and get a second opinion. And then come to the appointment. No longer with what they think is the second opinion, but based on all the data that you also have. So you will be faced with a patient that is just basically using their rights of natural person. We Europeans gave them these rights. Now, are we as professionals prepared? I don't think so, but we will get ready. Don't worry. How do we do this? The internist integrates. I hope this is my basic and key message. The internist integrates. So if all the things I've said are complicated, well, I'm sorry, but that's the reality. Get used to it and study it. I mean, take 5 minutes every day and learn about what is an avatar, what is a virtual patient, what is a virtual heart, what is the metaverse, because you will need to live and work in that space. There's just no other way. So that's a problem. And how do you do it? The internist is the new Kiwi professional. So if you have time, you can read more about this Kiwi concept: knowledgeable, intelligent, wise, and interoperable. I don't have the time, but in the slides, which we will make available, you have some Spotify from me, so you can hear the Spotify tomorrow on when you drive with your car to your hospital or whatever. We have nothing else to do. You just hear Spotify about what I call the Kiwi model, but very simple. Profound knowledge, to know what we know, is a key skill. Always been important, now is fundamental. Intelligent does not mean AI, it means hybrid intelligence. You need to be intelligent to use artificial intelligence. Otherwise, you're just dumb with AI. It's a dumb AI. And then wise, you need to trust and know when not to trust, or when not to use the AI. And of course, interoperability has been mentioned. By the way, we Europeans approved in Article 83, European Health Data Space Regulation, that member states shall develop and implement or provide access to training programs and provide access to information for health professionals. This is in the law. This is a regulation. It's not a directive. It enters in full force in 2 years. So this is not an option. This is something that is by law compulsory in Europe in 2 years' time. How do we do it? How do we participate? So I leave you just some projects that I'm running. SHIA is a training project where we're developing material to educate IT professionals and healthcare professionals. And there's the key R's, and people can get engaged. So thank you very much.
Thank you, Henrique, very much for your presentation. It was really interesting. So now we have some minutes to have a small discussion, questions maybe from the audience. You can use the chat we have here in this room to ask to the panelists. And by now, I would like to make like a summary. I think it's very important, the quality of data, and so we are the source of this data sometimes, many times, because maybe we have blood analysts, we have the CT scans and so, but the clinical data that we have to put into the system in order to get information of what is going on with the patient, it's our duty, it's our function inside the system. So internists are very, very important. And as we all learn, we have to be very, very, we have to give the clinical data as we learn it from the last 2 centuries. So clinical data, it's very important. Symptoms and signs, from the physical examination, it's very, very important. And the only way, or one of the main ways to get them, is that a physician pick up this data from the patient during the clinical interview. So I think in here our role is really, really important. Well, we have a comment from Charmin Kanta. It's a nice presentation indeed. Will AI be game changer and rule over human? What do you think? Yes, Enrique, yes.
Well, I can go quickly. No. No, it will not. It will not, because for one reason is that actually I was very motivated by, I can answer this. I was having dinner here with a very famous AI professor here in Korea. And I asked him that question. It's about, could AI filter the hallucination of another AI? And he told me that there's actually a very famous paper. I didn't get the reference, but I can try to find it out. There's been an experiment where they two top AI researcher groups did put one AI to train the other AI, and the result of this was that after many iterations, they literally collapsed. So when you use AI to generate data to train the other AI system, they somehow, this is sort of they mess up and they just literally collapse. The program collapsed, and to the person. So I don't think it will happen. We will always need a lot of humans in this loop, and we can decide to stop using. This is a little bit like nuclear power. We don't have to use everything we've developed just because we've created it. If we think it's not going on the right track, let's take a step. That's what I would say. Optimism.
One concept I like to think of, and I'm trying to learn, is that the machine doesn't have the willingness of acting. No, this is something that only human can do. Even if a process can be automatized in a very long way, and you can feel that the machine is automatic, but there has to be always someone at the beginning to begin the process. No, what do you think? Do you think that could be like an answer to that question of will AI substitute humans? Do you think that there's anything that we can think on it, like the most powerful concept on saving us from this substitution?
Can I say something?
Yes, of course.
Yeah, I think getting back to our profession, I think there are two important parts of our profession. One is competency, other is compassion, right? So I can still think the AI can cover the competency bit, but the compassion it won't be able to cover. And I think the people say it, at least I cannot see it in the foreseeable future, because in Japan, they have tried some robots which could be as compassionate as doctors or nurses, but it didn't work. As far as the automation you mentioned, that yes, you remember the famous thing about the chess player and the AI. I think the AI did beat the world champion, and it took them, but so they were able to make the so-called decision by themselves. Because when you're playing chess, you don't need to start, because you are making your own decisions. So, but when it comes to our profession and our impact on our patient's outcome, then I think we need two parts. One is the compassion, other is competency, many others. So I feel that is the way I see it.
Mm-hmm. Thank you.
I agree with this idea, and I think it was also what was expressed also by Oleg. That is, they say that is something that the AI can learn from humans. So I don't think really that the AI can replace completely the humans. I agree with the professor.
I have another question. Do you think now that we have new tools, new technological tools, we can think on doing different things? I mean, doing different kind of medicine in order to achieve different goals in the treatment of our patients, or I mean, not only to make prevention, of course, this is 6P medicine and so, but inside the clinical workflow, do you think now we have the opportunity to make other kind of functions or activities during our working day. What do you think, Filomena? Do you see us doing different things in the next 3 or 4 years?
I think I hope that we can use the tools to reduce all the workload that is not really, we don't need to do, no? All the administrative work. I dream that they really to use these tools to this smart transcribe, no? To avoid to stay hours and hours on the computer just to say to do something that really is not necessary that we do. I don't know how many years we need to change this attitude, because it's I mean what I feel is really that people have fear of technological changes, because everybody is very it feels very safe in what they know, so they don't want to learn new things, because just they don't. For example, we were the first department that start using electronic health records, and what was very difficult for us is to make people understanding that it was an improvement, and our best outcome was that at the end, after 2 years, we had a new nurse. And he said, I don't want to work in a department where there is no electronic health records. So really, we changed the attitude of the people, but it was very, very difficult. And still, we have some, for example, in the unit, in the anesthetist, they don't use electronic health records because they say that it's too difficult for them. And nobody says that it's impossible not to use it, because all the hospital is using, all the ASL Roma say is using, but they still say for us it's not good. Why for us it's not good? It's just not possible to do something different from the other, because is a matter of collecting data, no? So we don't have the data of the emergency unit because they don't use them. So intensive care unit, we don't have data because they just use only paper. So it's just crazy for me. But it's really changed. This mind is difficult. And so for me, the difficulty that I see is really humans, the state of mind of the humans.
Thank you.
Yeah.
So do you have any questions to the others?
Yeah,
Sorry, Ismail, I'm
good.
just checking at the time. Is that okay? I mean, we can ask questions, but
No.
Are we over time now?
Yes, we are over time. Maybe 1 minute, one more question, small if you have, but if not, do you have any questions?
We are
No,
good.
I think it's just the comment, your last question. I think you indirectly touched upon innovation, because the whole idea of having the digital and data means that we as a human, we as a profession, we need to think how to solve the problems in different ways. And I think the medicine being changing, I show you the first slide that over the last 200 years, but the change was very slow. Now the change is very fast. The reason is this, that first we have got the mindset, second we have got the tools.
Yes, you're right.
Well, I'll give you my comment as well, Ismail, and then you should shut us down and send us home. A few years ago, I was asked by the dean of my medical school, because I'm a little bit of a provocateur, as you've noticed by now, to give a keynote for the first year, something strange, different. That could be an eye opener. And I thought, what should I say that could be not a commonplace? And I ended up doing a talk that I named A Medica. So A Medica, which means without medicine. And basically my argument was very simple, and this is my final words. If you want to do different, why do you need medicine? because people have problems, right? Because people have pain, because people have suffering. If there was no suffering, if there was no diseases, there would be no doctors, there would be no need. So the ultimate goal of medicine is actually to cease to exist. I mean, if you want to do it different, because the internists are, I always say this to all my friends that are not internists, the mother specialty, right? I mean, as a mother specialty, if you think about this metaphor, your role is to make your children capable of living without you. That is the ultimate purpose of a father and a mother, right? Is that they produce an offspring of happy people that can continue to live happily when they disappear. So I'll leave you with this idea. Do we have the courage to move backstage, designing systems, designing powerful AI tools that allow patients not to need us anymore, or at least not to need us every day? Because some people aged over 75, you know what they tell me? Oh, this week I have an appointment. Next week I have another appointment. They live in hospitals. This we can change. I don't think this is the medicine of the future. And maybe that's why the shortage of doctors is actually an opportunity to rethink. We need more high quality medicine and less low quality quantity. But you have ideas for the next sessions. Whenever you need us, just let us know. Thank you very much, Ismail.
Anyway, I think the model is a mixed model, no? No, it's always this. So I think that the message is we will remain
Okay, Filomena. Of course we will.
In the backstage, but we will stay.
So it was really a very nice talk to you, nice chat. So thank you very much for the three, Filomena, Henrique, Mahmood. I know we are going to go forward working in a working group. So thank you, and let's go forward.
Thank you.
Thank
bye
you.
bye.
Thank you.
Bye bye.
Bye bye.
I want to say thank you, Ismail, because it was working very hard for this webinar, and it was really a success. I think really I thank the professor and the other professor for the presentation that were very interesting, and I learned a lot in this session, and I hope that also people that they participate learn a lot. Thank you, Ismail.
Perfect. Thank you.
Thank you.
Good evening. Bye bye.
Bye bye.